All right. Well, thanks everyone. I'm really happy to be here. I always feel like ACHD is the weird younger cousin of heart failure, so it's sort of like a little bond that we have. I have no disclosures. We're going to start with two questions. We'll end up repeating the questions at the end of the talk where I'll put up the correct answers. So we'll start with this first one, which is a 33-year-old man with a supracrystal VSD is seen for 9 months of dyspnea. His exam has a 3 out of 6 holosystolic murmur at the left sternal border and a diastolic decrescendo murmur and bibasilar rails. His NT-proBNP is elevated, and an echo shows a dilated left ventricle, 162 ml per meter squared, EF 50%, and moderate aortic regurgitation. His pulmonary artery systolic pressure is 45 millimeter mercury. An MRI demonstrates a QPQS of 2.9 and aortic regurgitation fraction of 42%. What is the best next step in management? Is it A, a cardiopulmonary exercise test, B, VSD closure and aortic valve repair, C, sacubitril valsartan, metoprolol, and pagliflozin, D, transplant evaluation, or E, ambrisentan? So I'll give everyone just a second here to scan in. Not working? All right, everyone can mentally come up with a right answer then. Okay, so we have the majority of people looking for VSD closure and aortic valve repair, and a minority of people wanting to do a transplant evaluation. All right, second question, a 41-year-old woman with tricuspid atresia, status post a staged lateral tunnel Fontan operation, is undergoing evaluation for heart transplantation. Which of the following is the strongest indication for a combined heart-liver transplant versus heart transplant alone? Is it A, a FibroScan value of 18 with an F4 scale of severely elevated, B, a liver biopsy with grade 3 bridging fibrosis, C, a liver CT with cirrhotic morphology, or D, an EGD with esophageal varices? Bit more of a spread on this one. Okay, we'll come back to them and give the right answers at the end. So briefly, this talk is going to be 3 parts. We're going to quickly go over the demographics and general principles of patients with heart failures. We'll talk about when it's appropriate to use GDMT in ACHD patients, and then we'll finish up talking about transplant in this population. So, there's been a revolution in the care of patients with congenital heart disease over the last 40 or 50 years to this point, such that the vast majority of patients with congenital heart disease survive to adulthood. They all used to die as kids, but cardiac surgery got much better, neonatal ICU got much better, ACHD care got better. But it turns out that patients with congenital heart disease still do die primarily of cardiac causes. So if you look at these graphs of patients with moderate complexity congenital heart disease and high complexity congenital heart disease, you'll see that the majority of patients with ACHD still are dying of cardiac cause, and the dominant cause of cardiac mortality in patients with ACHD is heart failure. So I'm glad you're here because the management of heart failure in ACHD patients is still critically important. So learning point number 1 is heart failure remains the dominant cause of ACHD death in the modern era. There's some keys to thinking about how to manage heart failure in patients with congenital heart disease. And the first and most important one is not unlike acquired heart failure, but specific to ACHD, you really want to look carefully for reversible anatomic causes of heart failure. And these are going to be different from what you're used to seeing in your patients with acquired heart failure. Heart failure in congenital heart disease is more likely to be due to valve dysfunction, residual shunts, or outflow tract obstruction. And a key point is you want to address those anatomic defects before turning to typical heart failure medications. A second point, which we'll talk more about, is that GDMT is appropriate for some, but not necessarily all patients with congenital heart disease. The more they look like your patients with acquired heart failure, the more applicable GDMT principles probably are. So patients with congenital heart disease and heart failure due to systolic dysfunction of a systemic left ventricle should probably be treated with GDMT, but this may not necessarily be true in patients with the systemic right ventricle, as we'll talk about, and there's really just vanishingly small data about patients with single ventricle anatomy. And then finally, device therapy comes with different costs and benefits. So because of complex intracardiac anatomy and residual shunts, the calculus about when to put in something like an ICD, a resynchronization device, MCS, or even transplant is different in this patient population. The risks are different and the benefits are less well established. So starting with our first point, before turning to medications, look for reversible causes of heart failure: shunts, valve dysfunction, pulmonary vascular disease, and arterial obstruction. And whenever you're faced with a question where you have a patient with heart failure and residual anatomic lesions, you really want to focus on fixing those residual anatomic lesions as your primary modality of treatment. So what are some examples of this? If you're presented with a patient with an aortic coarctation and they're presenting with left ventricular systolic dysfunction or refractory hypertension, before putting them on instead of primarily putting them on medical therapy just to treat their hypertension or GDMT for LV systolic dysfunction, it's critically important you do a scan to look for evidence of residual arch obstruction. This may be a CTA or an MRA. If you have a patient with a Fontan circulation who's presenting with progressive Fontan failure symptoms, you're going to want to look for anatomic problems within that Fontan circulation. You're going to need to do probably a catheterization to look for evidence of pathway obstruction. You're going to need to search for occult arrhythmias that might be driving the heart failure in that population, and you're going to want to treat those issues primarily. Then if you have a patient, let's say, with LTGA or congenitally corrected transposition of the great arteries who's presenting with heart failure symptoms and significant regurgitation of their tricuspid valve, which is their systemic atrioventricular valve, this is a patient where you treat them as if, for example, they were a mitral regurgitation patient in conventional anatomy. You're going to want to address severe symptomatic valve dysfunction as the primary source of the driver of heart failure. So, read that question carefully. They're probably not going to get you super deep in the weeds of esoteric congenital anatomy on the heart failure boards. I imagine they'd probably point you towards an identifiable anatomic lesion in the question. They're not expecting you to be congenital heart disease experts, but they may expect you to know this principle of treating basic anatomic conditions first. So just to restate what I restated, if it gives clues about a residual anatomic lesion, treat that first. So, I'm jealous of the data that you guys have in acquired heart failure about the use of GDMT. We have nowhere near the same quality of data in ACHD patients. We would love it. We don't have it. The patient populations are small. The anatomy and physiology is diverse, and we don't do a good job of randomizing into large clinical trials, so we're left extrapolating. So the question is, when is it appropriate to use GDMT to treat patients with heart failure? And I'll just give this nutshell first, and then we'll go into a little bit of the data. The first point I'll make is that for the most part, if patients have a biventricular circulation, they have a systemic LV, meaning an LV ejecting to the aorta, and they're presenting with LV systolic dysfunction, we have pretty decent evidence that GDMT is appropriate in this population. And I'll say we also feel more comfortable extrapolating from the data in acquired heart failure. It gets a little trickier when you look at the patients with biventricular circulation and a systemic RV. There, I think the data is weaker, but we'll talk about some of that data, and we'll talk about some use of device therapy in that population. And we really are in a black box in terms of medical therapy in patients with single ventricle physiology, status post of Fontan operation. I don't think it would be fair to test on the use of GDMT because it's idiosyncratic, institution dependent, and there's really not a good evidence base to say what works and what doesn't in that population. So let's begin by talking about GDMT and resynchronization therapy in patients with biventricular circulation, a systemic left ventricle, and heart failure. So most of our data is retrospective, and then again we extrapolate from the acquired heart disease literature, but this is a large retrospective study that came out of the Mayo Clinic, looking at over 4,000 ACHD patients with a systemic LV in a biventricular circulation. And what this panel on the left shows is that LV systolic dysfunction is common in patients with ACHD. So if you look at all comers, the prevalence of LV systolic dysfunction was 12%, which is pretty high for a population. And that was distributed both in patients with, quote, right-sided lesions. This would be things like tetralogy of Fallot, Epstein anomaly, shunt lesions, as well as patients with left-sided congenital heart disease. That would be your congenital aortic valve disease, coarctation, sub-AS, things like that. So LV systolic dysfunction is actually quite common in diseases like tetralogy of Fallot, for example, actually even numerically and statistically more common than it is in patients with congenital left-sided lesions. And what they found is that after initiation of GDMT or CRT, these patients had improvement in their LV systolic function. And this was true both in patients with right-sided lesions and in patients with left-sided lesions. So GDMT, at least in this retrospective study, as well as CRT in this retrospective study, resulted in improvement in LV systolic dysfunction. We also have other retrospective studies in the ACHD population showing benefits of ARNIs, SGLT2 inhibitors, and their effects to reduce heart failure hospitalization, improve New York Heart Association functional class, biomarkers, and LV function. So with conventional anatomy, conventional therapy is typically indicated. Biventricular circulation, systemic LV, these are TETs, coarcs, ASD, VSD, PDA. We have a Class 2A recommendation in the 2025 ACHD guidelines to use GDMT in that population when the patients have LV systolic dysfunction. A Class 2A recommendation that CRT is reasonable in this population, and a 2A recommendation that when patients otherwise meet conventional indications for an ICD, ICD therapy is reasonable. So in a nutshell, you can extrapolate the data from your acquired heart disease patients. We have weaker recommendations than you do because the evidence base is substantially less robust, and the benefits just haven't been demonstrated the way they have in acquired heart failure. So let's talk briefly about systemic right ventricles. So systemic right ventricles, you'll remember, really come in two populations. You have your patients with DTGA, who've undergone an atrial switch procedure. These are your mustard and Senning patients. And you have your patients with LTGA, or congenitally corrected transposition of the great arteries. Both these populations are going to have a systemic right ventricle. So I'll tell you that particularly after DTGA, event-free survival is poor after the atrial switch, the mustard or Senning procedure. This is a bit of an older study comparing patients with DTGA atrial switch to the Dutch population. And what you can see is that event-free survival at age 40 is quite low, and even survival free of transplantation is only 80% at age 40. So these patients have a large number of events, and heart failure, again, is the driving event in these patients. A more recent study from JACC in 2022 looks at outcomes following your first, basically, episode with DTGA. This purple line, the worst Kaplan-Meier line on this, is your overall survival following your first heart failure encounter with DTGA. So what you can see is that presenting with heart failure is a morbid condition for patients with DTGA atrial switch procedure. So these patients experience a lot of heart failure. So what do we know about the use of GDMT in this population? It is messy, but we'll go through it briefly. So ACEs and ARBs, we have one negative RCT that was a little over 10 years ago now, looking at valsartan, looking at RV ejection fraction and New York Heart Association outcomes. That was a negative trial, but it was a small trial, and we have really inconsistent observational data. ARNIs are a very interesting story in the systemic right ventricle patient. We have conflicting and complicated information, and I'm going to slow down on this one just for a second because I think it's important. We have a series of observational papers showing improved outcomes with ARNIs in patients with a systemic right ventricle in terms of improving RV function and functional class. These are retrospective observational studies with all of their limitations. And then we have one randomized trial called the Paris RV trial, which you may have seen. It was put in the European Heart Journal. This was a negative study